That's great. So I'll say good afternoon now to everybody. Welcome to Province Healthcare St. Paul's Grand Rounds. I'm Marshall Dahl, Division Head for Endocrinology at UBC St. Paul's or Providence and BCH. Before introducing a couple of reminders, I'll ask people if they could remain muted through the talk. So just check your microphones, please, and have them turned off. Most people choose to also take their video off so they're not a distraction during the talk, so I invite you to do that, but please feel free to put the videos back on when we come to question periods. The chat button will be enabled with the invitation. There's a Grand Rounds evaluation form, which you can fill out both for feedback, but also to allow for continuing medical education credits. A final comment just for introductions is that the endocrinology lecturers are actually the beneficiary of a legacy philanthropic donation from Dr. Martin Hoffman, who goes back a number of decades. And Dr. Hoffman's funded really, in our view, a fairly prestigious ability to have wonderful guest lecturers over the years. And we are using the Hoffman Lecture Fund and recognizing Dr. Hoffman and his family's contribution today. So we're really pleased to be able to resurrect the rounds after an interruption by the pandemic. Otherwise, Dr. Ott would have been here speaking last year. So moving on, it's a great pleasure to introduce Dr. Susan Ott, who graduated from Stanford University, attended medical school at University of Washington, residency at University of California, Davis, and then returned to Seattle for a fellowship in nephrology. And like a lot of people in nephrology, early research studies involved aluminum bone disease in dialysis patients and responses to calcitriol. And this, of course, leads in turn to studies of calcitriol in osteoporosis. And that was at a time when bone mineral density machines were being developed. She's continued with studies involving bone histomorphometry and osteoporosis and other diseases, has been an investigator in several large clinical trials of osteoporosis treatments. She's been a member of the Kidney Disease Improving Global Outcomes, KDIGO International Committee, which helps define chronic kidney disease, mineral and bone disorders, and helps formulate clinical practice guidelines. She continues to be concerned about long-term problems with osteoporosis medications, and that leads to, I think, one of the great titles for rounds today, which is the seductive short-term effects of osteoporosis treatments. So Susan, we'll turn it over to you with a screen share, and looking forward to the presentation. Thank you so much.
Okay, thank you. So let's see, screen share right there. There we go. Now let's try going like that. Okay, so that's the title of my talk, and oh, there we go. I don't have, currently I don't have any conflicts of interest. And I'm going to introduce it by saying that osteoporosis is common, but it is not simple. Hip fractures are one of the most important reasons that older patients lose their independence. And the spine fractures can lead to this serious kyphosis with the disfigurement. It distresses the patients. They can get reduced pulmonary capacity. They can get heartburn, and it's uncomfortable. So this is what we want to prevent with our treatments. Now, one of my goals for this whole talk is to maybe give a better visualization of what's happening inside your bones, both normally and with osteoporosis, and then basically the physiology of how these medicines work. So we can understand, and it's a lot more than just looking at a bone density. So this is a lovely image from Ralph Mueller of human young trabecular bone from the vertebra and osteoporotic. And you can see this is nicely connected, strong bone. And how does it get from here to here? Since I do histomorphometry, many of these slides are going to be based on that work. And this is what it looks like under the microscope. We stain the bone green. This would be a normal, and you can see here that the trabeculae are thicker, they're better connected, they form a network that's stronger than in this osteoporotic biopsy. If we zoom in a little bit, Actually, this is my own biopsy a long time ago. And hopefully this is a normal biopsy. It shows the osteocytes, these little cells, the osteoid surface that stains red, and the rest of the marrow space. And if we zoom in even further, this is what we call a bone metabolic unit. And it includes the osteoclast cells here, the new osteoblast cells that are tall and follow the osteoclast. Then the more mature, the older osteoblast cells get thinner and thinner until eventually they turn into lining cells right here, or osteocytes in the middle. So we're going to start out with a few animations of what's going on in a normal bone metabolic unit. And these diagrams are just cartoons. They're not drawn to scale. And so we start out with our pre-osteoclasts, single nuclei cells floating through the capillaries in the bone marrow. We have our stromal cells, our osteocytes that have a network, almost like a neural network, and our stromal cell, another stromal cell here. So this little red dot is representing sclerostin, which is an inhibitory protein that the mature osteocytes tonically secrete in order to prevent you from forming bone. Let's get to the next one. Okay, so what will happen is you get some micro damage. There we go. And that's going to signal the osteocytes. Some of them are going to undergo apoptosis. Others are going to secrete factors that will cause the initiation of the whole cycle. So here's the factors getting secreted. That causes the lining cells to fuse with the capillary, and that allows these pre-osteoclasts to come into this special space, which is our resorbing space. And meanwhile, the stromal cells proliferate, again, with some of these growth factors, these little growth factors, and they start making some pre-osteoblasts. Now, the pre-osteoblasts and the osteocytes secrete rank ligand, and that attaches to the rank on the pre-osteoclasts, and they fuse to form these giant osteoclasts that now will resorb bone. And the lifespan of the osteoclast is largely determined by the estrogen level. So if you lose estrogen, they actually have a longer lifespan. But eventually they undergo apoptosis. And then the osteoblasts make osteoprotegerin to put a brake on the process, and the osteoprotegerin blocks the rank ligand. And now we're going to start forming the bone. So you proliferate, your stem cells proliferate, some of the osteoblasts proliferate, they make a team. Team goes down to that surface, starts laying down collagen, which is colored orange, and then it mineralizes, which is colored light green. And the cells undergo apoptosis, or they remain behind to turn into osteocytes, or at the end, they turn into lining cells. And eventually they reconnect the osteocyte network. They start making sclerostin again. And the mineralization gradually increases until you're back to where you started from. And now we've repaired that area of bone. Now I also want to show some higher detail of what happens. The osteoblast is secreting collagen. And this is cleaved on each end. And I'm telling you this because I want you to understand what's going on with the markers. I'm going to be talking a lot about markers and what they're measuring. And so the P1NP is formed every time you secrete a molecule of bone collagen. You're going to generate a P1NP. So the more you have, the more bone you're forming. Okay, now these molecules of collagen they're extracellular now. They line up always in the same pattern. They're the same spacing in every direction. And that spontaneously causes a covalent bonding right here at the end of every molecule. So there's one bond at the N-terminal end, and there's another bond here at the C-terminal end to the adjacent collagen molecule. Then time passes. On average, in the trabecular bone, this is going to be about 5 years. In the cortical bone, maybe 10. But the osteoclasts will now come by and secrete cathepsin K, which will cleave this collagen in specified places. And so we have these small fragments that are called the N-terminal peptide and the C-terminal peptide. And so these are measuring the same thing, just different assays. I haven't noticed any particular advantage of one over the other, except that I like the one in the urine because my patients like that. And you can either get the urine NTX or the serum CTX. And every time you have an increase, that means you're resorbing more bone. Okay, so now we're going to show what happens when we put all this together in what we call one BMU. Because not only do we go in and out, but the BMUs travel along the surface for a while. Okay, there's our crack, there's our osteoclasts, followed by the osteoblasts, followed by the formation of new collagen, mineralization. Notice the color is light, means not mineralized very much, starts to get a little darker. And I purposely have different shades of green here representing different degrees of mineralization. Normally you have everything from very mineralized areas to very lightly mineralized areas. Okay, now we step back a little bit further, and from here on, the space and time are actually accurate, representing measurements from bone histomorphometry. So I have a series of little clips here showing what happens. So missed one. Okay, first we go, this is just a normal bone, and we're going to show 3 months, but we're going to speed it up. I mean 3 years of, oh, sorry. There we go. So this is how we're refreshing our bones and keeping our bones alive and healthy. Okay, so what happens with menopause? Well, the major thing, a lot of things happen, but the major one is the osteoclasts are going to resorb a little deeper and they're going to resorb a little longer. So you're going to get, keep an eye out for it, micro damage and perforations. And there's going to be a little bit more reaction by the osteoblasts. They're going to try to make up for it, but they don't quite make up for it. So we're going to develop a little high turnover here. And notice that there's, you know, if you resorb from both sides of a trabecula, you're going to get what we call perforation, and then that doesn't fill in very well. And so this is actually shown in another method by using micro MRI of the tibia, and this was done in normal women as they went through menopause, baseline, and then 1 and 2 years later. And if you see this blown up, I think it was right in here, you can see that there's these perforations, and here's another area where this bone has just dissolved away. And so this process starts happening right away after menopause. It's also measured by the NTX. So this was a study of nearly 1,000 women who were just normal women throughout the country who were near the age of menopause. And so they measured various parameters for about 10 years, and then they realigned all the data according to the last final menstrual period. That's time 0. And you can see that 2 years before the last period is when you start to have the bone resorption. The estrogen is getting lower. And then 2 years after. This is actually mimicked in bone density, only in the other direction. Your bone density starts to go down pretty sharply a couple of years before and after the last period. So what happens if you treat with estrogen and SERM? I'm going to show you this. So this is going to be our bone. We have a little bit of osteoporosis now. And at 6 months is when we're going to give the estrogen. So you'll see 6 months of the turnover and then what happens when the drug starts. Okay, now we give the medicine. And these changes are actually subtle. What you're doing is you've turned down the bone resorption and consequently the bone formation, but not that much. So you still have some formation and resorption going on. But what you don't see is the important thing. It's like Sherlock Holmes and the dog barking in the night. You don't see the perforations. So I think the main reason these drugs are so helpful is that you're not getting those perforations, which cause a lot of loss of strength. So now we look at what happens to the markers. And this is an older study. They used an older marker formation. But with estrogen and with raloxifene, your markers of bone formation go down modestly, and your markers of bone resorption also go down a little bit more, but still they haven't gone all the way down. So you're still able to repair a lot of the damage that happens with everyday life. Now we're going to look at the same thing, only bisphosphonates. 6 months of turnover, then you're going to see the little blue diamonds that represent the drug. They're going to come and attach where there's bone resorption, and they're going to stop bone resorption. And then consequently, they stop bone formation. Okay, so let's watch. And after a while, there's not very much formation anymore. And you might have noticed that it's starting to get a darker color. And that is because there's now, since you're no longer turning it over so much, the mineral can deposit. And so you get more and more mineral deposition, and it all gets to be fairly homogeneously dense. Also, because you're no longer really able to resorb bone, you can't resorb away the cracks. And so they accumulate. So we do have markers that go along with this. So this is a study of alendronate. When you give the drug at time 0, the markers go down quite a bit for both resorption and for formation. But note that the resorption markers start going down right away within a couple of weeks, and they're down something like 80%. The formation doesn't go down for a while, and that's because in the very beginning, all those areas that are still finishing up the formation that started before you gave the drug will finish up, and that can take up to 6 months. And then it starts to they start to go down because you're not making any more new areas. And although the markers are only going down about 60%, when you look at it under the microscope and actually measure it, at least in the iliac crest, it's going down more like 95%. Okay, so this is going to be really very different. Now we're going to use teriparatide, and we're going to start giving that at 6 months. And we're going to see both increased resorption and formation. It goes pretty fast. So Now we start. And now we stop, because that's about as long as some of the studies of the histology go. But we have gotten more resorption cavities here and here. We've actually got a more complex structure. We've made more bone than we've dissolved. So the net effect is that you have gained bone and you've gained volume of bone. And you might notice that the mineralization is actually lower, because this is all brand new bone. It hasn't had a chance to mineralize. That mineralization process can go on for at least 3 years. So that's why even after you stop giving the drugs, the bone density is low. You're not making any more bone, but you're making the bone that you have more mineralized. And the markers show that as well. So here we have a study here by Finkelstein, where they started the drug at 6 months. And
yeah.
Are you using your regular home phone?
Nope.
Okay.
so somebody,
Michelle Johnson, can you mute your mic, please? Thanks.
so the P1NP goes up really strikingly, but it comes down again. You develop a resistance, and also the NTX. So you're having both formation and resorption going up. All right, now we're going to look at the opposite. Denosumab is the most powerful anti-resorbing medicine that we have. We're going to give an injection at 6 months, and it just turns it off. So this is what'll happen. Again, for the first few months, you fill it in, and then it just sits there and gets more mineralized. Now we're going to skip a dose. And right away, you get a lot of resorption and perforations that are going to happen as soon as the rank ligand is exposed again. All right, so whoops. And here's the markers showing the same thing. Both the serum CTX and the P1NP both go down quite dramatically with the Denosumab, and they stay down as long as you give it. And what we don't show here is when you stop it, it goes. And the final one is romozazumab. So this one is different than all the others, and it increases the bone formation and decreases the bone resorption. And this one actually goes really fast, because the action of the increased bone formation is only about the first 6 months. So at 6 months, we'll give the first shot of the Romo. There we go. And it just woo. But then you kind of revert back to some normal turnover again. So the net effect is a lot of bone. And again, it's very new bone. It's not very mineralized yet. And down the line, it will mineralize more. Oops. Now you can watch that once more here. Okay. And so you see the P1NP level goes up, not quite as much as with the teriparatide. And then it comes down again pretty soon, reaches a baseline on the average. 6 months later, a few people will go till 12. But the CTX goes down. And so the medicine actually is inhibiting resorption as well as stimulating formation. That makes it unique. So now, without physiologic basis, I want to talk about the actual title of the talk, which is what are the long-term effects of the medicines? And I want to ask with each one, what happens when they're discontinued, and what's the long-term effects? And so we start with estrogen. And I start out with this slide just because so many physicians are not aware of it. It's an old study done when alendronate first came out, and they looked at ordinary healthy well, I think, yeah, they were healthy postmenopausal women who were between 40 and 60 years old. Fairly good number, and they gave either placebo, alendronate, or estrogen in a randomized trial. And the bone density improved better with estrogen than with alendronate. I'm also not showing it, but there have been 3 studies in older women who have osteoporosis or who are in their 70s. And in that case, estrogen and alendronate have a similar benefit, but in no study is alendronate better. Now, if we look at estrogen in the long term, we don't see this anymore because of concerns about cardiovascular issues when you start it with an older woman. But prior to the Women's Health Initiative, there were a lot of women taking estrogen that started taking it at menopause, kept taking it. And in this study of nearly 10,000 women, they were all older than 65. And the mean duration of estrogen use in the ones who were using estrogen was 24 years. And they followed these women for another decade. And during that time, the ones who had been taking estrogen had a significantly lower fracture rate compared to the non-users. So by the time we're here, these women had been taking estrogen for 35 years, and they're still having a benefit on the skeleton. The older observational studies have shown that the hip fracture rates in the women in their 80s on estrogen were somewhere between a half and a third of the women who are not on estrogen. So you can use estrogen, especially for the skeleton, lifelong, and it helps the bone all the way till the end. We could talk the rest of the day about other effects of estrogen. So I'll go on. What happens when you stop? Well, this was actually studied in the Women's Health Initiative. And eventually what happened with the fracture rates is that the estrogen women, the women who'd been on estrogen, caught up to women who were on the placebo, but it took a little while. In the women who got the medroxyprogesterone acetate along with the estrogen, they caught up with their placebo group after about 4 years. And in the women who had only estrogen because they had had a hysterectomy, actually 5 years later, they still had a lower fracture rate than the ones who had been on the placebo. So it's fairly safe to stop estrogen. You will get a little bit of decrease in the bone, but the fracture rate is not going to show any surge. Now, with bisphosphonates, the bone strength decreases with time. And so this is shown, I think, best in some biopsy studies. They did biopsies in women who'd been on bisphosphonates anywhere from 1 to 17 years. And they looked at the strength of the bone with some biomechanical kind of testing and the number of cracks in the bone. And there was a steady increase in the number of cracks. And there was an increase at first in the strength, but then it turned somewhere around 7 years and goes down again. So it's a small study, and we could definitely use more information, but it does parallel what we're seeing with fracture rates. And this is just what the cracks look like. You do a special stain and you can see that they accumulate. And there's several studies showing they accumulate with long-term bisphosphonate use. There's another study, same thing. And they're not repairing the damage. Now, the other thing that happens with long-term bisphosphonate use is that the bone accumulates mineral. That's the same process that happens in this dinosaur bone. This bone is not any bigger than it was when the dinosaur was alive, but it certainly has a higher bone mineral density. The same process happens with logs, and I just show the difference between, this is a tree that fell over and cracked while it was a living tree. This is a tree that had turned into a fossil first. That's a picture from the national park, the petrified forest. And this fracture happened after it was a fossil. And it's a very sharp fracture as opposed to the splintered fracture. And it just reminded me of the x-rays of our patients who have the atypical fractures with long-term bisphosphonate use. They have this very sharp edges on the lateral side versus the typical hip fracture, femur fractures in a woman who has osteoporosis, where they're not transverse, they tend to be more spiral or oblique, and they're more splintered. So the nature of the bone with all the mineralization is going to be different, and you can get more fractures. It's another example of the prologue of these fractures is you get a periosteal reaction. The bone's trying to repair the damage, and the periosteum still can react, but then it makes it cut right like that. And the incidence of these fractures does go up. There are several studies now. And this is just showing one from Southern California because they had a program where all the fractures were looked at. They looked at the x-rays of them and they could sort out the ones that were atypical. And then because it was at Kaiser, they knew who was on the drugs and who was not on the drugs. And the rate goes up according to how long you've been taking it. And it really, by the time you've been on it for 9 years, it's about 1 in 1,000 women were getting these atypical fractures. Now, what's probably more important is what happens to ordinary fractures. And here we don't have the kind of data we would like. We really need more. But this was one study that was worrisome. And it was the observational part of the Women's Health Initiative that had 97,000 women. And 5,000 of them had used bisphosphonates for more than 2 or more years. And they looked at the duration of use compared to the incidence of hip fractures. These are just ordinary osteoporotic hip fractures. And they saw that after the prolonged time, the more than 10 years, the adjusted hazard rate was actually significantly higher than it was at 2 years, suggesting that perhaps with long-term use, even the ordinary hip fracture rate was getting worse. And we need to have more data, but it is difficult to study this because there's a lot of confounding, and especially since a lot of women are now worried about it. You know, they can either stop because they're a really high risk anyway, or they can stop because they're very health conscious and they've read a lot of literature and decide to stop. So they're very difficult studies to prove, but it's definitely a concern. Okay, so we'll just say that there is a concern about the long-term increase in fracture risk and decrease in bone strength. What about discontinuation? What kind of trouble would we get into if we discontinue? And this is one study that's been misquoted so many times I'm thinking of writing an editorial about it. And it was called the FLEX study. It was the follow-up of the first alendronate study. And all the women had already been on alendronate within the first trial called the FIT study. And this is, they had all been on alendronate, and then at 5 years, they were re-randomized to continuing in alendronate, which is shown in the red line, and taking a placebo, which is shown in the white line, for the next 5 years. And this is looking at the NTX. So this is what I had showed you previously. The NTX goes way down when you start, and it went down in all of them. But look what happened when you stopped. It stayed down, even if you took placebo. So, I mean, the red line is no surprise, but the white line is showing that 5 years after you stop taking the drug, the bone turnover is still suppressed. And there's now several studies that have shown that. But what's really important is what happened to the fracture rate. So here's the fracture rate. This was in the FDA report. Now, the FDA report was the one that, in my opinion, was the least biased way of reporting it. And they looked at the cumulative incidence of all of the fractures. And they had 3 groups, actually, 2 different doses of alendronate, and then the placebo group. So they had all taken alendronate at time 0 here. Now, look at the green line where they switched to placebo. The fracture rate is not any different than the ones who remained on alendronate. So you might as well take the placebo because you're not getting any more benefit from that continuing use of alendronate. But on the other hand, these placebo patients are going to have a much lower risk of the unusual atypical fractures. Now, it's been said that, well, but if they have more severe disease, if they have actually T-score lower than 2.5, then we should stay on the alendronate. But here is the data, again, the same presentation, but now they only look, there's a smaller number, but these are only the ones whose T-score was lower than 2.5 at the hip. And it's the same. So the ones, even these green lines, they all had osteoporosis, but they had the same fracture rate on placebo as the red and black line. So my take on bisphosphonates is that it's no longer effective after 5 years. It's safe to discontinue it at least for the next 5 years. They have a lingering effect. And they're still going to really be used in a lot of patients. So this is one situation where you can get the benefit of the increased bone strength for those first 5 years. We'll have a lingering benefit for the next 5 years. After 10 years, we really just don't know. And nowadays, we're getting more and more patients who've been on it, off it. Now you don't know whether to put on and off again. And I don't have time to say too much, except that what I tend to do is look at their markers. And if the NTX starts going up, then I'll consider giving them a little bit more, giving them a booster dose, so to speak. Okay, now we're going to switch to teriparatide. And when you discontinue teriparatide, you lose what you gained. So this is shown in this study. This is only 1 year, but they took teriparatide for a year and then stopped. And the green line shows that it goes down again at both the spine, and you get a little bit, but at the hip, it goes down again. And this can be prevented with either raloxifene or a bisphosphonate. Also, teriparatide with long-term, it's no longer effective at forming bone. There seems to just be some kind of switch, and you can't push the osteoblasts to form anymore. And so when you stop it, you do have to switch to an anti-resorptive drug. Otherwise, your benefits all disappear. Oops. Okay. Now, Denosumab has some real problems with stopping. And this was the first long study called the Freedom Trial of Denosumab. And in the first 3 years, as shown on this graph of bone density, the red group was given Denosumab, the blue group was given placebo. And you saw this nice increase in the bone density. And then at year 3, the blue group was also given Denosumab. So they're just 3 years behind. And they followed these two groups for 10 years, well, for 7 more years after the study. And at year 10 from starting, Denosumab in the red line and year 7 in the blue line, they discontinued it and saw a pretty dramatic drop within just 6 months after they stopped, actually. And it was even more so in the total hip, where over 10 years, they had gained about 8%, but within 6 months, they had lost all the way down till they were 6% lower than when they started. And this has now been shown in several other studies. And what's happening here? So this was a really interesting paper by McDonald, and they're in Australia, it's published in Cell. And they discovered a cell that hasn't ever been seen before. And they've named them Osteomars. So what they saw was that in patients, well, mice actually, in mice who had been had a rank ligand inhibition, which is what Denosumab does, there were cells that were circulating that had characteristics of the mature osteoclasts. They had the same protein profile, but they only had one nucleus. And so they weren't pre-osteoclasts. They were actually fission cells. So the osteoclasts, when they blanked red glycan, instead of undergoing the apoptosis like they normally would do, they underwent fission, and they just split up into these little cells with all the machinery to resorb bone. And when they would culture these cells and then add some rank ligand, they would immediately fuse into making a giant osteoclast, which could then start resorbing bone right away. And these cells accumulated with duration of Denosumab use. So far, there's actually only one paper about this, but it was a really fascinating paper, and it would explain this very fast rebound bone loss that happens. And there are clinical consequences to that, and it has been described now in quite a few papers that patients who are on Denosumab and then stop, and especially if they've been on it for a while, get multiple vertebral compression fractures. This was one of the earlier reports, and you can see this patient developed fractures all down her spine. Here's another, this is one of the patients I saw. Another doctor had started Denosumab, and she skipped a dose and had a whole series of fractures. And the clinical features of these patients were described in 35 patients, and they had 35 patients had 172 fractures after they discontinued, and they averaged about 66. The time was 11 months after the last Denosumab. And remember that the first 6 months is when the Denosumab is still in your system. So they were starting to see this only a month after we think that the medicine wore off, up to about 20 months since their last injection. And they also described, interestingly, that 12 women had vertebroplasties with 58 new fractures within the following days. And so if you did have one of these, you should not do a vertebroplasty. What can you do? So there's one case report of giving back more Denosumab. So they had one patient who decided to stop, and 7 months later, she started getting new fractures. So they quickly gave her another dose, hoping to prevent the progression, but it didn't work. So as you can see, it's still going to get more fractures. How about using Zoledronate? And this is one study where patients who'd been on Denosumab for 7 years were treated with Zoledronate, and they didn't lose as much, so it attenuated the loss, but they still lost about 5%, a little bit more than that, even with Zoledronate. There's been a couple of other studies trying to figure out what's the best time to use Zoledronate. I think we don't really know yet. There was one that did this complicated protocol where they gave it right after the 6 months, or they waited for 7.5 months, or they checked the NTX and did it when the NTX went up. And in all of them, the bone was lost. This happens if you've been on it for a prolonged time, more than about 3 or 4 years. There's also several studies that if you've only been on it for 1 or 2 years, you can actually prevent this rapid bone loss with Zoledronate. And this, of course, is an area of a lot of active research because it's a relatively new problem. Oops. Switching to teriparatide is probably not a good idea. This was an older study that was looking at, they called it data switch study. And I'm just going to concentrate on the red line here, where the patients got Denosumab and then switched over to teriparatide. So they got Denosumab for 2 years and then they switched, and this is looking at various skeletal sites. So in the spine, it went down and there was a bit of a recovery. in the radius, it went down and kept going down, even though they were on teriparatide this whole time. And in the femoral neck, it went down quite a lot. And so same with the total hip. So switching to teriparatide is not really going to prevent this bone loss, especially in all those fractures of the spine. I just wanted to put in something because a lot of patients, I mean, I've seen a lot of patients who are put on Denosumab because it's not metabolized by the kidney. And what I'm going to say is not being metabolized by the kidney is not an indication for using it. And it doesn't mean it works. It just, you know, you want to know, is it effective? And is it safe? We're not sure if it's, I think it might be effective, but I'm not very sure about the safety. And there have been reports of a very high incidence of serious hypocalcemia. And by serious, I mean coming in with status lepticus, laryngospasm, tetany, needing ICU calcium drips, arrhythmias. So there's no randomized trials in patients with chronic kidney disease. There's one study from Japan where they avoided it by giving lots of calcitriol. And I'm not sure how wise that would be in the long term. We're really not sure what that's going to do on the vascular calcification to have to pour in so much calcium to try to make up for this. So I think we need to be very cautious in our patients with kidney disease. And then if you decide that you want to stop, then you have to decide, are you going to give them zoledronate, which most people think is not indicated in CKD. And so you're kind of in between a rock and a hard spot there. I've had to give zoledronate to some kidney patients, which I don't usually like to do. Okay, so Denosumab, the long-term risks are not yet defined. Some cases of jaw osteonecrosis and atypical fractures are seen. So, you know, the idea that, well, the answer to this problem with stopping is just don't ever stop. Just give it 6 months, every 6 months for the rest of your life. That may not be feasible in a lot of patients. And we don't know. The atypical fracture reports are just the way they were with bisphosphonates in the beginning. A few here, a few there, people not believing it, a few more. So the same with jaw osteonecrosis. In the trials, they've got jaw osteonecrosis the same incidence as in the long-term bisphosphonates. And I already told you about the fractures, and we don't really know how to manage it. Okay, not too much about romozazumab. It's too new to say anything about long-term. But after a year, it's not effective anymore. So we have to give an anti-resorbing drug. If you just stop it, though, you're going to lose a lot of it. And I think this is pretty fascinating. I'm not sure why you lose so much because you've made all this bone. And I was wondering if maybe that you could maybe get osteomorphs there, but I asked the authors of that McDonald paper, and they said they hadn't looked at that yet, but they said they were going to, so stay tuned. But you can follow romozazumab with alendronate, and you get a lasting effect. And this also translates into really significant reduction in fracture rate. Okay, so, well, anyway, that's my final slide here. For each medicine you start, my take-home message, you should have a plan for how long you're going to use it and what your follow-up is going to be. And this is really critical for the injectables. So I think we have a few minutes. How are we going to do this? Stop share.
That's great. Thanks. We're doing fine on time. Susan, that was really great. It was so interesting, too, to be able to move from the basic physiology and then with a reminder that a lot of things that people use as a surrogate marker, which is bone density, does not reflect the differences in architecture, the differences in mineralization. And, so those insights were helpful, and then often doesn't affect outcomes. I'm sure there'll be a number of questions. I haven't got anything in the chat box, but I'll bring them to attention. I was also curious if there are data about the use of zoledronate as a primary agent in terms of its durability or our preferred time of cessation or risk benefit? Does it vary appreciably from alendronate, for example?
Yeah, I mean, it's a little bit stronger, and otherwise physiologically it's awfully similar. So it's just maybe like it's probably would be what you'd get if you gave a higher dose. There are studies on, it inhibits an enzyme in your osteoclast, and some pretty cool studies that show here's the drug, here's the bisphosphonate, and here's this enzyme, and they can measure how close the drug fits, and the ones that fit the tightest are the most potent. And then on the other end, they bind to hydroxyapatite. And so the ones that fit to the hydroxyapatite more closely have the longest duration. And it turns out zoledronate fits into the pocket of the IPP, whatever, foreign FPP enzyme. It's tightest, and so it's the most potent, and it sticks to the hydroxyapatite more closely, so it lasts longer. But otherwise, physiologically, it's the same. And I usually use it either if the patient has trouble orally taking it because of compliance issues or memory issues or heartburn, then I'll just switch them to the IV form. And for some of the older people, it's just so much more convenient to just have one dose. So
very good. So patient-specific factors for your decision-making. I've got 5 questions in the chat box. We'll go through as much as we can. Well, first was just, what would be the drug of choice in chronic kidney disease then?
Yeah, good question. Right now, there's problems with all of them. The studies of raloxifene are small, but at least they're showing that it hasn't had any side effects and you get a slight improvement in bone density. None of the studies are good at looking at the overall rate of fracture. The first thing you have to do is try to correct all the things that we know are wrong, like with parathyroid. A lot of your kidney patients are going to have high PTH. There was a study in stage 5, where if you had a PTH over 300 and gave cinacalcet and you were older than 65. So for our older people, they had fewer fractures. So that was the only one that actually had data on fractures, but it was only helping in the older ones.
So generally do all the general things to look after bones in renal patients, and then small studies for a couple of those agents.
Yeah,
next question. Raloxifene in particular. Next question, any comments on when to start an agent after hip fracture?
Oh yeah. So there are some questions. I know they're debated, that one study showed if you gave it within a couple of weeks after the fracture, it maybe didn't prevent future fractures as well. And so since I'm not sure about that, and it just seems like you ought to give the bone a little chance to heal before you block it all, I think that the ideal time would be when they come in for their 6-week visit, because most orthopedics surgeons, that's kind of the time, because you don't want to wait too long because they're going to be at high risk of getting another fracture. So around about 6 weeks is what I'm saying, although I could have my mind changed if somebody did a better study.
So a bit of physiology on that time, but mostly about the practicality, getting them before they escape.
That's part of it, yeah.
That's right. Another one, given the FitFlex study data you presented, oops, it just went off my screen. How long of a drug holiday do you recommend? Is it 5 years?
Yeah, I recommend, what I do is after I stop, I'll wait a couple of years, and then I'll start getting the NTX. And when it starts going up, that's a pretty good sign that it's not working. Your drug's not working anymore. And if it's right away, if it starts going up right away, it should stay down for 5 years. If it doesn't, then you need to wonder what else is going on. I mean, maybe they became hyperthyroid, maybe they got another fracture somewhere, maybe they've lost weight, you just need to reeval.
Thank you.
I should mention one caution about the NTX, because you can tell that I am one of the people in our field who favors using the markers to help you decide. If you've had a fracture, then it makes the NTX go up just in the repair of the fracture. So if somebody had a fracture, you need to wait at least 4 to 6 months afterwards, which is a little frustrating because sometimes that's really what you want when you want to know what was going on. You can't use the NPX or the P1NP right after a fracture. Okay.
Thank you. Another question in the chat box: would short-term denosumab be useful followed by zoledronic acid for a few doses? Also, how long would you use zoledronic acid post denosumab cessation, and would you consider shorter duration between infusions? Sort of the practicalities of that approach.
Yeah. Let's see, I'm doing short term. Well, my feeling is if you're going to end up with zoledronic acid, why don't you just start with it?
But what if patients have already been on denosumab? So the problem is you have these patients, they've been on denosumab short term. There have been some studies, as you said, that if you use it maybe 2 years and then give them 1 or 2 doses of zoledronic acid, that would probably mitigate the loss effect. But if they've been on it for 5 years or more, and now you're at a situation where, how do I stop it? I know Aaliyah Khan had presented some data about lowering the denosumab dose and tapering, but that's not practical. And then the question is, well, should you give zoledronic acid every 6 months rather than 1 year? Because we don't have access to measuring bone markers as easily as they do in the States. So then it's just a matter of clinical judgment or measuring a bone densities, but they're all going to lose. The question is, would there be any benefit of giving, multiple small doses of zoledronic acid, or maybe something shorter acting like bemidronate?
No, I think that's a really good question. And I've tried that a couple of times. I mean, I've gotten away with it, but I can't go as far as recommending it. We've tried giving, the doses, standard dose is 60. So then I give 30 and then I gave 15. I don't know. I've heard of other people and you still are going to lose some. So let's see. I think when they come to me, when people come to me and they're on denosumab, I pretty much switch them over to zoledronate. And I don't see any reason to stay on denosumab with the exception of people with cancer. So they're another whole thing. If you got cancer, it's a more effective drug. But if short of that, I would like to get them off of it and onto zoledronate. And you should be able, maybe you could talk them into, talk your, I guess it's your government into paying for the markers in these situations where a lot of people who didn't think we should use markers have changed their mind when it comes to helping you to decide what to do after the denosumab. So you could at least get a couple of them, because one of the things that one study showed that they gave zoledronate and the markers went down, but then they actually came back up again within a few months. So they needed a second dose. If you couldn't do the marker at all, you might just empirically give one dose at maybe about 7 months after your last denosumab and then do another one about 5 months later. This is an area where there's a lot of research. So we have to keep in tune, but I just want people to be aware that it's a real problem.
Thanks very much. I apologize to the final 2 people in the chat box. We're not going to have time to move on to questions now with the schedule. I just want to thank you so much, Dr. Ott, for fascinating and also practical lecture, just again, going from physiology through clinical trials, through your own experiences and the choices you make based on that information. It's been extremely helpful for all of us. I'll just thank everybody also for attending today, and again, recognize Dr. Hoffman, whose sponsorship of this lectures we can all commemorate with us. Reminder to fill out the evaluation forms that came with the invitation, and wish you all a great day.
Thank you.
Best of luck, everyone. Bye-bye.
Thank you so much.